Now, Dr. Zhang is going to start today's surgery using the Explorer, detecting the individual tooth mobility, checking the individual tooth mobility. As you can see, this lower anterior teeth, the resin bonded and the added wire splinted the situation, cause of prevent the mobility. However, the already resolved all of this alveolar bone around this root, it is impossible to save. So finally, all of these four lower anteriors should be extracted, will be extracted. Okay, the very simple extraction will be done. Yeah. Yeah, Dr. Zhang is suggest to patient about this lower canine area, number 33. Yeah, orthodontic procedures combined with implant fixation is another, the one option. However, Dr. Zhang is suggest to patient cause of, Dr. Zhang said to the patient age is older. The elder patient difficult to get the orthodontic procedure during 6 months, even though the 6 months and 1 year sometimes the feeling too long time. So Dr. Zhang is going to have extract this canine and the fix two implant on 42 and 33 as same as the treatment planning. Okay. Basically, as you know, number 43 area, the canine, the opposite, the canine, the already extracted. Actually, long times ago, depending on some of malocclusion and also the poor the periodontal condition. So number 43, the canine tooth was extracted. Now, actually, as you know, just only 4 anteriors and 1 canine existed here. So this canine have some tricky situation, right? Okay, now the Dr. Zhang is start to have extraction of this canine tooth. This canine too much protrude on the labial side, labial positioning, and the crossbite to upper dentition. So the poor situation. Okay, the space is enough. And yeah, the saline irrigated, the extraction socket. All of this extraction socket should be thorough. the curettes, remove all the remaining the granulation tissues. That is our first step. The basically first step is a traumatic extraction when we have immediate implantation, normally, right? However, this situation, this sort of situation is already the gone, the alveolar bone surrounding tooth. So lower anterior, for anterior is the meaningless of a traumatic extraction. However, this 33 area should be a traumatic extraction. The prerequisite factor before starting immediate implantation, right? Okay, now Dr. Jung has to make an initial point here. Due to labial version, the labially positioned, so Dr. Jung make an initial point for osteotomy on this 33 area, the lingual socket wall, and also the move to 42 area to also give some indentation on the lingual socket wall with a high-speed bar. And after that, changing the drill, the bright surgical Lindemann surgical kit. The first Lindemann drill was applied for the proper positioning and the proper osteotomy. The proper osteotomy was started using this Lindemann drill. As you know, the normal drill speed of 1000 and the 1500 RPM with cell line. And the checking the osteotomy site, and the insert bright the parallel pin to checking the axis. I think that is better. That is good position to make a final restoration, supported by 2 implant fixture. And the opposite side, number 42 area, started with the Lindemann drill on the lingual socket plate. The very simple drill procedure for bright TL. Insert the parallel pin to checking the parallel, the position and space, the mesodistal space for the final restoration. All of these conditions should be evaluated before the final osteotomy, right? At this time point of using the Lindemann drill. As you know, the Lindemann drill, this Dentium Lindemann drill, all of these Dentium drill system have a white band, middle portion of the drill. The bottom of white band, the 10 millimeter or 9 millimeter. The 10 means supine style, Implantium supine. The previous system have even number, the 8, 10, 12, 14, like this one. However, bright system and anal line system have an odd number, 7, 9, 11, 13. So this bright system have an odd number, the bottom of white band 9 millimeter. And the top of white band means 11 millimeter. So Dr. Jung is going to have compensate the narrow diameter on this area. So 11 millimeter length could be chosen. After final, during the osteotomy, Dr. Jung is going to use this bone graft material for the gap filling. Gap filling means between implant surface and the socket wall, the filling with these graft materials like a particulated bone or the collagenated bone. some of surgeons want to have implant fixture insertion first and gap filling next. However, Dr. Zhang is preferred to have bone grafting first and then installation next. Depend on surgeon style and concept. However, Dr. Zhang want to have a tight, compact filling between implant surface and socket wall. This type of technique give us a better initial stability when we have not enough the wide diameter and taper system implant, right? So this bright tissue level, the patty valley style, the middle portion of fixture is bigger diameter than apex and top portion. So all the initial stability getting the middle part, the contact to the cancellous bone. So this bone grafting first procedure and technique is good for the matching, good for this system. And another part, diameter 3.0, 11 millimeter. So good for immediate socket, immediate implantation. Very nice, well done. The insertion torque, as you know, to control the depths. Basically, as you know, the anterior portion for the better aesthetic outcome, the aesthetic emergence profile, the insertion depth is very important factor, right? So how much deep insertion of the fixture on this area is very important factor to getting better the emergence profile and final restoration outcome. About this bright tissue level, for me, the top portion of these fixtures, the matching to the neighbor cement to enamel junction, that is good point to the depth control, right? So once again, top portion of fixture matching to neighbor TS cement to enamel junction, CJ, right? That is good depth control. Looks here. And another socket areas packing with the particulated bone, osteon geno. The gap filling concept, gap filling technique procedures can be applied on the intact socket area, right? All the socket area, socket wall should be intact case. Is a good candidate for the gap filling procedure. However, unfortunately, some of the loss of wall, like buccal wall, the labial socket wall, deficiency case, actually you need more procedure, a little bit more to do, something to do more. What? A GBR procedure using the barrier membrane and the fixation. Sometimes you're going to use pin fixation like this one, right? Cause of the missing lose some of the socket wall means a little bit complex procedure, more complex procedure. However, fortunately, this case, all of the socket wall was intact. So Dr. Zhang tried to simple bone grafting, called as gap filling, after insertion. Very simple. Intact labial, the buccal bone wall, the simpler procedures that will be performed. However, the loss of this bone socket wall, especially buccal and the labial, means a little bit complex procedures. Procedures will be complicated. And okay, after bone grafting, connect with scan comfort cap. There's a scan comfort cap working at three different function. First one working as a scan jig. Second one working as healing abutment. Third one sometimes using temporary abutment for the temporary restoration. Especially Dr. Zheng prefer to use longer this scan comfort cap. There's a scan comfort cap, the longer scan comfort cap. Now he is checking the parallel, the axis of the implant fixture, because he want to see from the lateral part of the patient for the better estimated. Okay, so retrude this implant fixture and then turn to lingual for better the axis and insertion again. Okay, good. Yeah. Now here's reverse torque, give a reverse torque the implant fixture, and then changing the axis a little bit lingually and insert again, right? Okay, good. Yeah, very nice. To make a better axis. In future, you want to make SCRP type, or screw retained type prosthesis. He want to make this screw retained type. So he need more, the little bit the tuning, the axis of the implant fixture for the better the outcome on this area, the final restoration. Okay. Removing the excess bone graft material. And he may use a collagen graft cover all of this exposure socket area. This one is the key point of today's surgery. You can see, as you can see, no, not any displacement flap of this the labial area, right? No vertical incision, no the periostal releasing incision, no some of expanding the flap. It means you can save the keratinized gingiva, the original portion, without any reducing the keratinized gingiva. So original the positioning with this the soft tissues, the only covered with exposed areas covered by collagen graft. So in this kind of situation, the collagen is a best option to closure of this exposed area, right? This collagen graft holding the underneath graft materials, the already inserted the bone graft materials, osteogeno, the bovine bone, and holding and accelerating the soft tissue healing to make a faster soft tissue closing. And after that, maybe, underneath bone graft materials and the blood clot and the holding on these areas with some stability, higher stability, right? So stability is very important factor to make a new bone formation in the GBR field, right? So cell scale stability also important, and some of graft materials scaled stability also the important factor to get the better and the good result when we have a GBR and some of minor bone grafting procedure, right? So how can we get the higher stability. So the easier way is here. Just to put the collagen graft and the simple suture and holding the periopack. And that's it. This periopack, the cover and protecting from the outside invading or some the irritant or some pressure. And just underneath this pack, the collagen graft, the protecting once again underneath bone graft materials with the blood clot. So give a stability twice bigger, so the faster soft tissue healing and the bone graft can be stable. All of this situation is good for newly forming bone when you have a GBR and minor bone grafting procedure, right? Very important, the considering factor. Okay. Actually, as you know, this 33, the left lower canine area is a big exposure socket, right? So the labial version, labial extrusion, the natural teeth extracted already, and then implant insert a little bit the lingual position. So big empty spaces between implant surface and socket were on the labial part. So packing the bone graft first and cover all of these exposed big large areas collagen graft. So this collagen graft working protection and give us stability. The regenerative materials for using this kind of situation. So if you want to have a simpler way to have a GBR procedure or some bone grafting procedure, you're going to choose the better and good the regeneration material and combined with the good the implant system, and that kind of combination give you a free. So now Dr. Jung is feeling free suture for the final finish line. All the exposed and extracted areas are closed by a suture technique. Now Dr. Jung is feeling free and comfortable the final suture situation. Okay, very nice. After a surgery, they're going to have intraoral scanning for the temporary restoration, right? Temporary PMMA restoration during healing stages. That is normal procedure for the Dr. Jung's digital protocol combined with the bright TL system and this simpler bone grafting procedure. Almost done, actually. Due to this, the canine areas implantation, patient doesn't need anymore the orthodontic treatment. He doesn't need orthodontic treatment at all. So time saving and the feeling free also the patient, and that is good news for the patient also. Now he gonna make a sling suture for the intimate flap closer, this buccal flap, to getting intimate the closer to the abutment, right? The sling suture, using the sling suture. Okay, now all implant procedures with the bone grafting was done very quickly and very calm and safely and comfortable situation. And now here's injection PDRN promoting soft tissue healing and underneath bone grafting stability and transforming the new bone formation. The PDRN is also the good material to accelerate it, the cell differentiation. Now, a bright oral pack is applied on this surgery area. The longer the scan abutment is the reason for this holding the oral pack. Okay, the surgery was done. Thank you for waiting for this post-op pictures, photos, and the Q&A session. As you can see, this post-op situation here, the very nice, looks like a stable and the good closure, the good suture situation. A bright oral pack applied after this suture procedure, and this oral pack helping faster soft tissue healing and give some stability underneath these bone graft materials and the implant around it, the situation area. And post-op PA is here. Two implant very well done with a parallel and good positioning inserted with a very nice depths also connect with the healing scan healing abutment 11 millimeter. What about the post-op CT? The very nice. About the number 42, can you remember almost the final time period Dr. Zheng is going to change some of actual wall of fixture, right? So 42 is osteotomy, looks like a little bit better, little bit more the labial angulation. However, finally changing the actual wall, changing this picture positioning. So finally all of this the decision was corrected. Number 42, 33 is very nice, well done. Inserted implant fixture with connect with scan abutment. Now we have two questions today. First one, when is alveolar ridge preservation necessarily after extraction? Frankly speaking, and as you know, the immediate implantation is always better than the staged approach, especially on the anterior area, right? Why? Staged approach means bone modeling and remodeling. So the bone resorption horizontally, the buccolingually, and the vertically. So after that, when we have the implant insertion at this area, we have to more factor. We need more to consider. We need more to consider the factor, little bit depth and the horizontal widths. So frequently the bone grafting, even though the minor bone grafting situations will be happen, right? So however, the immediate implantation case, actually extraction and then implantation with three-dimensional proper the positioning and then the weight with the bone grafting and the weight during 3 months depending on the situation, and then the final lastration procedures will be performed. Nowadays, actually, as you know, the scanning and the simpler the digital ways are on your way, on your front, right? However, all the socket areas can be performed by immediate implantation? No. Some of cases are impossible or very difficult to get the initial stability. Depend on the big defect, big apical lesions, and periodontally the compromised situations. Already the defected areas, labial bone walls gone away already, and the mesial wall and distal walls are gone away already, and it is impossible to get the proper ideal 3D positioning with initial stability. So another checkpoint is infection, right? So all of these periodontally compromised areas, the easy to get the infection after implant surgery, cause of a remnant of the microbiomes affected these areas with negative action, right? So even though the periodontal pathogen that stay there during 3 months after extraction, as you know, right? So according to Dr. Hamley's suggestion, depending on the situation, we're going to treat with four different stages. So basically and simply, it depends on situation. We will have a proper decision on this socket area. First, intact socket and the small apical lesion under 2 millimeter case, actually good candidate for immediate implantation, right? However, except this situation, a small the minor defect like small dehiscence or the penetration defect on the labial bone wall, upper anterior, lower anterior case, also the candidate for the immediate implantation. However, the periodontally compromised situation, as I mentioned before, it is a necessary part to have ARP, alveolar ridge preservation, right? When you have an ARP case, what is a best combination? Depend on the surgeon and the scientist and professor give a lecture and give information with a different way. However, as a clinician, a simpler way is here. The bottom areas particulated bone compacted the packing, and upper part using with the collagenated bone like osteogenocollagen, and top portion sometimes you're going to use collagen membrane or collagen graft. That depends on the situation, right? I'm going to use some cases use barrier membrane, the collagen membrane, like a Dentium collagen membrane. In some case, just put the collagen graft, that's it, and wait 4 months, and then put the implant. Okay, so alveolar ridge preservation case, actually defected area, bone defect area. So missing the socket were especially labial area and big defect area need ARP procedure instead of immediate implantation, right? And number 2, how do you choose between particulate and the collagenated bone graft materials? Very good question, and also the tricky question. Which one is better, particulated bone and collagenated bone? Depend on the surgeon, depend on situation, depend on purpose. Basically, particulated bone and the barrier membrane, like a collagen membrane, is best combination already proved for the GBR procedure to make a new bone formation, as you know, right? So, however, sometimes little bit just a simpler bone grafting concept. Implant fixtures already inserted the native bone, however, need more horizontally little bit the width and sometimes vertically increase the bone cases. You can use this collagenated bone instead of particle bone plus membrane combination, right? already inserted implant surrounded by host bone, so it is not harmful and damages even though without any barrier membrane. So just to put the collagen native bone graft materials like a collagen bone, osteogenesis collagen, put the labial bone wall area, and then the added collagen, the graft or not, yeah, depend on surgery field, and just suture. That's it. This collagenated bone is easy to handle and stay there without any scattered on the surgery site. That is good advantages to choose this collagenated bone. However, this collagenated bone has some shrinkage during healing period. Why? Contain the collagen matrix. Collagen. This collagen is resolved during the healing period, time to time, and then a little bit shrinkage of the bone grafted areas will happen. However, compared to this collagenated bone, this particulated bone is volume of particulated bone graft areas more stable. So if you want to have a little bit more the bone volume and with the use of collagen membrane combination case, actually I suggest you use particulate bone. However, simpler bone grafting combined with collagen graft, or just put the socket area and some the augmentation concept, the simpler bone grafting concept, that you're going to use this collagenated bone graft material instead of particulate bone, right? So depend on purpose, depend on situation, depend on the surgery, the procedure. You're going to make a decision between the particulate and collagen bone. Okay? Thank you for watching today's monthly surgery video. Actually, it is spring at last now. The birds are singing and the flowers are blooming. Now the weather is very nice, so the spring is come already. Next live surgery in the middle of this spring, the April 24th, will be done by Dr. Park Jung-hyun, one of famous surgeon of Korea.